Hello, everyone. I hope that y'all can all hear me. Welcome to our event. Thank y'all for coming. I'd like to thank our guest speaker, Dr. Ketchy, for agreeing to talk to all of y'all about our event topic. There will be an opportunity for y'all to ask questions at the end. However, if you do have a question during the presentation, feel free to type it in the chat and we'll address it at the end. Elena?
Hey, thanks again for everyone for coming. And our guest speaker is a little more about her. Dr. Monica Ketchy has been an associate professor since 2015. She started, now coordinates, and teaches within the nurse midwifery and women's health nurse practitioner programs here at GCSU. Dr. Ketchy's educational background includes earning a doctorate in nursing practice at Augusta University, a postmaster certificate as an adult nurse practitioner from Northern Kentucky University, a Master's of Science in Nursing concentrating in midwifery from East Carolina University, and a Bachelor's of Science in Nursing from the University of Connecticut. She has 30 plus years of experience focused on women's health that includes caring for women throughout the lifespan and delivering over 2,000 more babies.
Thank you for that nice introduction. Thank you for the invitation for talking tonight. The topic I thought was an interesting one, that they said students selected the topic, something that they were interested in. I kind of like that. And however, I had to approach it with my background of what things are they looking for, not be too, trying not to be too nursing focused, but general population focused. But our topic tonight are the long-term risks of contraception on fertility. I think that is something that people worry about and are concerned about, and hence the question in our topic tonight. So I do have to back up and set a groundwork of knowledge of starting off with some basics of the menstrual cycle. I'm going to go through some information, and all of it in a very overview format, because I can teach classes on some of this stuff, let alone a 30-minute presentation. So I'm going to back out a little bit, do some overview information. But if there are more specifics that you want to know, certainly at the end, you can ask me more specifics. I'm hoping I'm hitting at the level that you'd like. Don't want to talk too basics because you are college students, and I don't want to talk to you like you're a medical provider or, you know, young either. So I think I've captured that middle ground. But ask me questions at the end if you want further in-depth information on a particular topic that I mentioned. I am going to share my screen. I do have a PowerPoint to guide me along in conversation. And keep me on track of the topic, because it is actually quite a very technical topic, hopefully not too dry, and that one that you'll find interesting. I do need to share my screen. And all right, I think you can see that one, and I'm going to start my play from start. All right, do you see the slides with the do you see the correct one? Do you see my presenter view, or do you see the one individual slide? Somebody answer. You see the correct one? Like only one slide, or do you see a lot of little slides?
Oh, a lot of little slides.
Ah, darn, wrong one.
You can see your presenter view right now.
Ah, okay, I got to switch. I got to switch sides then. Okay, I'm gonna stop sharing that. You know what? I'm gonna just unplug my second screen. Yeah, I'm a little afraid of doing that. Hold on a minute. Darn it. do you just see the one screen now? Or I know I do, so. Okay. Okay, can you see the one slide now?
Yep, we see one slide.
Okay, perfect. Okay, all right. Now let me make sure I can. All right, so long-term effects. This is my bit of my sense of humor. I apologize, I'm going to now be looking at this opposite screen, so I won't be looking at you specifically, but this other screen, but that'll work for me. And my sense of humor is to put Coco Pelli there. He is the god of fertility, so I thought that was amusing and thought it was funny. But if you don't know who he is, then you're wondering why this little guy is on the right-hand side. But then all our different contraceptive methods on top. So I considered that academic humor. But let's start off with some basics of fertility and just the typical menstrual cycle. A menstrual cycle is a just very big overview, is a monthly series of changes that occurs in the lining of the uterus. And that's the lining of the uterus is called the endometrium, and that prepares the uterus for receiving a fertilized egg. And so this begins at puberty, which some people that starts from age 10, and average age of menopause is age of 52. So that's a lot of years in there. So approximately, but it could be as early as 10, but average age of puberty is about 12, 13 years old. Approximately 28 days in length, this cycle, but some people are up to 35 days and some people are less days. So that 28 is an average. Hence, sometimes why there's an estimated date on things, because not all of us are exactly the same. Okay. All right. So there's an phases that the menstrual cycle phases. There's ovulation phases, and there's all different things. But I tried to again make this basic. And started this with just combined it and made it menstrual cycle. And the menstrual cycle, actually, the first day of the menstrual cycle is the first day of menses or your period. The first day of decent bleeding is considered the first day of your menstrual cycle. 1 to 7 days it usually lasts. That's when the uterine lining, that inside endometrium, actually breaks down and you have bleeding. And then the uterine lining repairs itself and prepares for an egg. Ovulation occurs around day 14 with the influence of follicle stimulating hormone, so FSH, and LH hormones, luteinizing hormone. And so that happens in the 8 to 11 and 12 to 17 is right where ovulation occurs. And then over in 18 to 25 and then 26 to 28, you have that if the egg is not fertilized and implanted in the endometrium, the FSH and LH levels decline, and then the breakdown of the uterine lining, the endometrium, and hence we go back to the menstrual cycle again to having your period. So this goes in a cycle. 28 days is average, and continues on through reproductive years. So what do we have to have for, I gotta move these pictures around my slides, okay. So what do we need to have for conception? Well, we need to have ovulation, where's the process of which the mature egg is released from the ovaries. We need to have fertilization, where the process that takes the place, it happens actually in the fallopian tube where the sperm meets the egg. And we have to have implantation when the fertilized egg attaches to the uterine wall. Interestingly, the chances of conceiving in any given menstrual cycle is less than 20%. Any condition that interferes with these events of ovulation, fertilization, or implantation that isn't caused from contraception may result in infertility. So what do we need to have? Factors that affect fertility. We need to have intercourse during the proper time, during ovulation. Sperm can survive, though, up to 5 days in the female genital tract, so it doesn't have to be exactly during ovulation. But the ovum does have a much shorter life expectancy, less than 1 day if it's not fertilized. If a couple is sexually active, 85% of women will be pregnant within 1 year, though, if a method of contraception is not used. So 85% of women who are sexually active and not using contraception will be pregnant. So that 15% is what people are worried about. So I did want to mention, though, we're talking about contraception and fertility, that I did want to take a step back and say a reproductive life plan for people is really necessary. There are different style couples, different life plans that people have. You know, we need to take it back and self-reflect and say, where are we on this spectrum or this timeline. So a reproductive life plan helps a woman, a man, or a couple think about their goals of maybe they want children or maybe not, or when do they want to have children. It's a plan that depends on their personal goals. I suspect, being in college, you know, having a child within this year may not be in your life plan. However, if it may be, I don't know, but where are you in that life plan? And offering family planning services, including information and access to contraceptive methods, is really a strategy to reduce unintended pregnancies so that people can plan when or when not they want children. And but yet, even with reproductive plans and contraceptive technology that we have, 50% of pregnancies are reported unintended, are unintended pregnancies. So what would be involved and why one would want a reproductive health plan is because, and we want you to make a plan and take action and see a provider, because everybody is different regarding pregnancy, your medical conditions, your lifestyle and behaviors, medications you might be on, vaccines you should receive during pregnancy or prior to pregnancy. Taking folic acid is healthy for pregnancy, stopping alcohol, smoking, and drug use, avoiding toxins, maintaining a healthy weight. Domestic violence in relationships, pregnancy does not help that type of relationship and needs to be addressed. In fact, it puts more pressure in a relationship and makes domestic violence exacerbate. Family history of genetic issues, mental health issues, all of these are important to have a healthy pregnancy. But if one chooses not to be pregnant, I wanted to start here about contraception. I will get to answer the question on infertility specific, but I wanted to talk about basics of contraception first, and then talk about understanding what these contraceptives do to say what do they do to fertility. So there's 3 different broad categories of contraceptive basics, and they talk about physiologic methods, barrier methods, and hormonal methods. I am going to talk very overview in all of these, and then answer any specifics that you might have. I do find contraception in general are very, I would like to say personality driven, because what you might perceive as an acceptable method, somebody else says, oh, no way. So there's a lot of different choices, and they can appeal to a lot of different cultures, lifestyles, personalities. But there's a lot of different choices. Okay, and yes, physiologic methods. And these are typical things that maybe you might think about, maybe not, but abstinence, I do like my little logo over there, is never fails, unless you're, unless you're married, abstinence never fails. And so, it is a method. However, if somebody doesn't have a present partner or chooses not to be sexually active, then they might want to have another method if an opportunity or a choice, they have a different choice or want a different choice later on. But abstinence is 100%. A method that people don't like to talk about, but I've mentioned, and actually in practice, I've seen it in certain cultures more than others, and people don't like to talk about it because it just makes people uncomfortable, is a withdrawal method. Proper terminology is coitus interruptus, but withdrawal. And that is where a male will withdraw before ejaculation. And this is actually about 70% effective, certainly better than no contraceptive at all. Doesn't cost any money, and not the best method, but again, better than none at all. Breastfeeding, when you, after having a child and you are breastfeeding, if your child is breastfeeding every 2 to 3 hours because of the hormone changes in your body, you don't ovulate regularly. It actually works as a fairly good birth control method until your child starts sleeping at night, or if you're supplementing any feedings. So if you continue to breastfeed your child consistently every 2 to 3 hours in the first 6 months of life, it's a very, very effective form of contraceptive. However, when your child starts to sleep in those feeding space, people will add in another backup method to help to make sure that to help prevent pregnancy. Natural family planning is a very effective, but a method that people have to be very proactive in using. It's taking your temperature to see when you ovulate and avoiding intercourse during that time, or watching the calendar a little bit of when you expect. If you really know that you have a 28-day cycle, do you know or can feel when you ovulate to avoid intercourse during those times? And also the cervical mucus method of noting that your cervical mucus thins during ovulation and thickens when it is not time, not time during ovulation. And so combination of those methods is, again, not as high as the hormonal methods, but is higher than not using a method at all, and is a preference for somebody who prefers to use a non-hormonal method. All right, some barrier methods. These are methods that are I would say, fairly common or known. A lot of these are over the counter, easy and accessible. Male condoms, I think that we know and understand the use of a male condom that I don't have to speak to. However, it is important that a male condom doesn't slip. A male condom is changed with any active intercourse, so that they're used correctly. Female condoms are not as often as used, but if somebody is concerned about STIs, a female condom is sold over the counter, a little bit more expensive than male condoms, but when used properly is a method choice that females can use. It gives the female back control than worrying about their partner having a contraceptive method. Diaphragms are a little disc. This is an orange picture on my screen that you put a vaginal cream on, and it's a little disc that's placed inside the vagina. That the cream that's put on it is a spermicide. It is used, placed in prior to intercourse, and the spermicide in there helps to kill any sperm. It is non-hormonal, and that's the draw to it. Only used during intercourse, so that you're not taking something when you don't need it. Again, effectiveness not the highest; it's in the high 80s. But people who want a non-hormonal method, this is a choice. The cervical cap is the one in the picture that I have in the screen in the right upper right corner with the hand holding in that person's hand. This works similar to the diaphragm, that it's placed in the vagina and it sort of covers the cervical os and adheres to it. You do need prescriptions for diaphragms and cervical caps, and they're placed in there with a cream as well, vaginal spermicide cream, and help prevent pregnancy from blocking sperm. as well as the use of the vaginal spermicide. Then sponges, they just get placed in the vagina and have a cream in them as well as a spermicide, and are sold over the counter. Vaginal creams, spermicide creams can be used. And there's a new approved FDA method recently called Phexi, and that is a cream in the vagina that affects the pH in the vagina that will kill sperm. So it works, a lot of them work in a spermicidal method. So those are really, there's a lot of them they either true barrier or are used as spermicidal methods. Okay. Now move on to the ones that you probably, my overview, I just wanted to say that the general advantages was non-hormonal. They don't require daily action when they only require action during acts of intercourse. Some are available without prescription. Some offer protection from STIs, which is very important. Your condoms do, and your female condoms do. The disadvantages, they do require planning. They require application at the time of intercourse and may be interruptive. And breakage or slippage of the barrier method at the time of intercourse may increase risk of unintended pregnancy. This is I think where you really do want your information, or the questions that you might have the most on, is these hormonal methods. I put pictures of all the different ones in it. You've got oral contraceptive pills, which I think people are very familiar with. You take a pill each day for 28 days. There's 7 days typically in most packs that are hormonal free, where you have a bleeding during that time. People often refer to oral contraceptives as birth control, although all of these things are birth control. So I will call them oral contraceptive pills instead of, but technically I'd love everybody to say that, but that's being too ticky-tacky for you guys. But oral contraceptive pills. Then there are patches. Patches you see the picture of a little patch, can be on the skin, and this patch stays on for 3 weeks and 1 day off. Then there's that little vaginal ring that can be put in the vagina for 3 weeks. Then there's an injection that's good for 12 weeks. All of these have estrogen or progesterone, or both estrogen and progesterone in them. They're just different forms of absorption. Same medication, different ways of absorbing through the body. So if it's via the skin, via the vaginal mucosa, or through the stomach and intestines. So all of them have estrogen and progesterone, different forms of absorption. The injection only has progesterone, and that's good for 12 weeks. If I needed to have a place for emergency contraception, it's not the method that I'd like people to use. However, it's certainly available in case there was slippage of a condom or unintentional active intercourse or lack of planning, and you wanted emergency contraception. There is one over-the-counter emergency contraceptive available. Sometimes you do have to ask at a pharmacy, but you do not need a prescription for it. There are progesterone IUDs. That's that little white picture at the top of the screen that is put in by a provider into the uterus. A little string hangs out of the cervical os, not the vagina like a tampon string. There are different forms of this. Some are good for 3 years, 5 years, have a progesterone in it that's slowly released, and is very, very effective, 99% effective for preventing pregnancy. Actually, I didn't mention the effectiveness of oral contraceptive patches and vaginal rings are up about 98, 99% effective. Depending on how good, I mean, if you're missing pills, then obviously it drops off. But if used properly, they're very, very effective, as well as the injection. An implant gets put into the arm, good for 3 years, and it slowly releases progesterone as well. A copper IUD is non-hormonal. I didn't have a place to put this, so I'm going to mention that. It looks very much like the IUD in this picture, but has a little bit of a copper ring on it. Its main effect, it doesn't have, you still have a regular period with this, and it's good for 10 years. It mainly causes, kills sperm, is how a copper IUD is works. So I wanted to mention as a group, how do these methods work? Well, they mainly work from stopping ovulation. So the hormones in the method work by keeping eggs from leaving the ovaries. They stop ovulation. Pregnancy can't happen if there's no egg to join the sperm. They thicken cervical mucus so that the sperm has trouble getting into, getting to the egg, and it thins the endometrial lining as well, so it has trouble implanting. There are some side effects of the contraceptive methods, and the most common is breast tenderness. Some people have some mild headaches, maybe a little nausea taking a pill, but then I would tell somebody to take it at the end of the day or take it with food. Take it at a consistent time of day, but it doesn't have to be first thing in the morning. Some people have some bloating. Some people find certain birth control, like oral contraceptives, there's certain ones that will help acne, and then there's some progesterone ones that may cause some acne. So you'll have some different effects depending on which one you're on. Some bloating and nausea as well. Particularly the side effect of irregular spotting on the IUD use or the injection. And that's just that, how I mentioned that the endometrial lining thins, you'll have this little spotting for the first few months because the endometrial lining, I said, thickens when it gets ready for pregnancy. And it just spots because it just doesn't want to thin out and rest. And so it's not causing you any trouble, but you get this irregular spot. That's very, very annoying, but not a problem. You know, not causing any medical issues is what I'm meaning. So those were the contraceptive methods. You know, so preventing pregnancy is the main reason people choose to use contraceptives. But I wanted to mention that there are a lot of benefits of contraceptive methods other than preventing pregnancy. People take oral contraceptives or use an IUD because they have heavy menstrual bleeding. People who are severely anemic might need to stop that bleeding or have really bad menstrual cramps that they can't go to work. When you put them on oral contraceptives, that menstrual cramping goes away. Some people have irregular cycles and they find contraceptive methods to be very helpful. People have endometriosis, is that lining of the inside of that uterus. When it goes a little, I'm going to just say goes wild, meaning not staying on the inside of the uterus, it might be in other locations, like on the intestines or on an ovary. The endometriosis is where the endometrium is located in other places other than inside the uterus. And people that when they have a monthly period, that uterine lining sheds and they have these severe cramps all throughout the abdomen. And so that's called endometriosis. And when we treat that with being on a contraceptive method. We can treat extra hair growth, that's hirsutism, polycystic ovaries, improvement of premenstrual PMS syndromes or PMDD symptoms. It does reduce ovarian cancer. It reduces endometrial cancer and colorectal cancers. And it improves acne, depending on which one, reduction of cysts, reduction of benign breast disease, and reduction of ectopic pregnancies because you're not getting pregnant. So there's a lot of things that the benefits of contraceptive methods that I want people to realize. And if you don't have any of these issues, you don't particularly think about it. You think about it for contraceptive purposes only. All right, so this is the focus that the students were interested in, is a contraceptive effects on fertility. And a popular belief is that hormonal contraception can have long-term effects on fertility, and actually, it's not true. It does not affect infertility. Contraceptive use, regardless of its duration and type, does not have a negative effect on the ability of women to conceive following termination of use, and it doesn't significantly delay fertility. Therefore, appropriate counseling is important to assure the women to use the method as to their interest. And so I had the research article that I cite in here actually was a combination of several research studies. They did a systematic review evaluating multiple different research studies, and there is no effect on fertility. However, I did want to probably address the question that I think some of the students might have had, and that was contraception doesn't, all right, let me continue here. Contraception does not lead to infertility. However, there is some confusion on the topic. Facts to know about fertility: when stopping hormonal contraception, that resuming a period can take some time on a regular period. Birth control can mask menstrual cycle irregularities that were there to begin with. And improvement of endometriosis symptoms and iron stores. So if you're not bleeding heavy and you're not getting scarring from this endometrium all over the place, may improve actually fertility. So keep in mind that a lot of these issues that people were put on contraceptive to begin with didn't go away. The symptoms got better, but you take them back off and it's back. But this is where I think the question that students might have is, what are the effects, the risk of hormonal contraception, maybe on your general health, maybe not on infertility, but on general health. So the American Cancer Society states that people who have taken birth control pills are slightly more likely to develop breast cancer than those who have never used them. However, this risk does go away when people have been off the pill for more than 10 years. And the American Cancer Society reports that taking birth control for more than 5 years may increase the risk of cervical cancer. The longer people take the pill, the higher their risk. However, the risk should go back gradually when somebody takes off. But I did want to say that it might increase it slightly. However, the main cause of cervical cancer is from HPV virus, human papillovirus, which is a sexual transmitted disease. But they did say that I wanted to present both sides and not just cherry pick the information to make it a positive skew. So there is a slight increase, but it does diminish over a period of time. Oh, I have an empty slide. Oh, let me go back. Hold on a minute. I'm presenter mode. Okay. I didn't realize this would do this. Okay, so I did want to present a few information about fertility facts. I wanted to define what is infertility. Infertility is a couple, no pregnancy with unprotected sex for 1 year in women younger than 35, or if you're older than 35, they do consider it for 6 months. So if you have unprotected sex for 6 months when you're older than 35 would be considered infertility, or younger for a year. The concern, it does actually, like I said, it's that 85% don't have any difficulty. So it's 1 out of 6 couples in the United States do have difficulty. And causes, 35% are from female infertility. We do tend to think of females more. However, 35% are male, 20% both, and 10% we just can't figure out a cause. Hold on a minute. Not sure I like this presenter mode on this. Okay, the rates of infertility based on age is 4.1% occur to women from the ages of 20 to 24, 5% 25 to 29, increasing with age 30 to 34 is 9.4, and 35 to 39 is 19.7%. So the reasons though, so it's not, I mentioned it's not contraception that's causing it. So what is causing infertility is the lack of ovulation, and that would be polycystic ovary syndrome or ovarian failure, and those are hormonal issues. Impaired transport, so if somebody has a blockage of the fallopian tubes, and that's because of endometriosis or pelvic inflammatory disease, and that you get pelvic inflammatory disease from sexual transmitted diseases where it goes up into the uterus and causes scarring and blocks the fallopian tubes. Inability to implant in the endometrium, and that's somebody with low progesterone, and so we put somebody on progesterone supplements and that to increase that. Or somebody that there's a chromosomal defect that causes that's the most often the cause of spontaneous abortion, or or the late term is miscarriage. Causes for male infertility, the true problems are again obstruction of the reproductive tract, causing the lack of semen. Hormonal disorders as well, producing pituitary gland and hypothalamus and testicle issues, hormones such as testosterone. These disorders cause an imbalance, including pituitary or testicular cancers. That's typically what it's from. Testicular failure to produce sperm, and abnormal sperm function and quality. That's the most common cause. Conditions or situations that cause abnormal shape, morphology, and movement. And that's one of the first things that they'll do in an infertility workup is look at the sperm motility and morphology to see if there is adequate sperm and adequate and healthy sperm. So let's talk about, I figured I'd end with enhancing one's own for infertility. The typical, I joke around about the, avoiding hot saunas and baths just because the testicles should be lower temperature to produce sperm. And women need to manage medications, thyroid, seizure, or psych medications, folic acid, sex during ovulation, limiting caffeine, because there is a relationship between caffeine intake and a slight increased risk of miscarriage. But men and women alike, good diet, regular exercise, healthy body weight, better sleep, less stress, avoiding toxins. I'm gonna move the toxins such as lead, toxic fumes, your environment, and being in a healthy environment. Smoking, alcohol, drug use, all of those do affect pregnancy and infertility, cause infertility issues. All right, and I have some references on there. So I'd like to stop sharing my screen and open it up to different questions.
I actually have a question more on the side of how certain birth control affects people's mental health, and how a lot of people will stop taking it because of the way that it messes with their mental health. So what do you suggest with that, and do you share anything about that?
Well, I mean, any contraceptive method, when you're taking estrogen and progesterone, it can affect moods, but I would not say that it affects everybody's moods. So it depends on that person, on how they affect their moods. If somebody is finding it is affecting their moods, there's a certain amount of medication that you have to take to make the contraceptive methods effective. If they find that, say that particular oral contraceptive they found did affect their moods, then I would say go back to your provider and talk with them and see if there's a lower dose estrogen and progesterone oral contraceptive that you could take. Also perhaps that might affect moods, or a different ones, because each one has a little different makeup, and perhaps that little change in it might be a difference. If you find that none of them are acceptable, then in that manner, then there are other choices, like a Paragard IUD, that copper IUD, which is non-hormonal. So everybody's different. I would not say that contraceptive affects all people equally. Can it have some effect on mood on some people? Absolutely. And then but I do find people who have benefits because it helps with their PMS. And so again, you have to keep a kind of a diary of what you're feeling. Go to your provider, let them know about it, and they can make or tweak changes accordingly and see what is the most effective for oneself. What else is on your mind?
Kind of going along with that, which contraceptive method would you say is the healthiest, and do any of them have like big negative impacts on your health?
Okay. Well, really what method would one choose really has to do with your own personal health history. So what is healthiest for one person? There might be somebody out there who really shouldn't get pregnant because they're an insulin dependent diabetic, and so and then there's somebody else who has no health history and are risk factors. So but if you have a history of migraine with aura, you should not be on any oral contraceptives at all. They're contraindicated. So you need to go through your health history, and that really is a personal decision on what is healthiest based on people's background. Now, like the injection I didn't mention has a the Depo-Provera injection, a little more increased risk of weight gain, about 1 pound, 1.4 pounds. It doesn't make you gain weight, but over a period of time, they've noticed somebody on it does seem to have a 1.4 pound weight gain per year. And it's not as effective in somebody who weighs over 200 pounds. So again, I wouldn't choose that to be for somebody who, it doesn't make you gain weight. But if you notice somebody gradually increasing their weight, then they need to change or increase their exercise, or or watch what they're eating. Watch it be a little bit more cognizant of calories in. So healthy is really defined on what that health history is, what your background is. The risk factors, like you do increase the slight risk of blood clots, but very, very minimal with oral contraceptives. But if you've had a history of a blood clot, should not be on that. But honestly, that's probably a very uncommon one, of a reason, a very remote chance of somebody getting a blood clot on an oral contraceptive, but there is that slight risk. Did I answer your question enough?
Yes, thank you.
Okay.
I was going to ask this one that somebody typed in the chat.
Sure.
So they said that they have heard a lot of negativity surrounding IUDs, like pain during insertion and removal, bleeding, etc. Do you think that there's specific reasoning behind that, or is it more?
Absolutely. Yeah. I've put in IUDs for years, and I know exactly what they're talking about. It's a little small T-shaped device in the picture. Placing it in a person who's never had a child, there is some pain with insertion. We will have them take ibuprofen ahead of time, or maybe give them a medication that helps open that cervical os a little bit to place it in. But when you're putting a device into a uterus, it can cause some cramping once you touch that cervix. So it is known to cause some cervical cramping with placement, especially if you've not had any children before. People say it's worth the procedure, the discomfort for, during the procedure for 5 years of contraceptive method that you don't have to take something every day and not be proactive with. But again, that's where I said they're very personality driven. Some people do not like the idea of a little device in them consistently, don't like that, don't want that. And so, but people like love them or they don't care for them. I find that two ends of the spectrum. Removing them actually is quite easy. It's the placement that can be a little, it can be uncomfortable. Yeah.
In what ways is birth control different in the US and other countries?
Wow, how it's accepted in other cultures and other countries. For instance, I take students on a study abroad trip to Tanzania. And when we were learning about the culture of Tanzania, I have to be over there, I have to be very careful about talking about contraception. Women's health issues. It's a very sensitive issue in certain countries. And I read an article. It was actually it's not the current president of Tanzania, but the previous one. And he said that women who use contraception are lazy. And I thought, wow, that's a different perspective, meaning that you should have lots of children. And if you use contraception, you don't want to take care of these children. And so, and I got asked from women in Tanzania when I was there why I only had 2 children. So people look at fertility and cultures are different in different countries, and look at contraception as differently. Spiritually, religiously, there's a lot of different backgrounds, but now the different methods. We do have the FDA, but I don't really think that there's different methods in other countries as far as the hormonal methods that I'm aware of, that in other countries of developed countries have other methods. I think we're all pretty synonymous on which ones we have and which ones we don't. But how they're perceived culturally, I would say, is different and accepted within the society. How would you feel about somebody saying that you were lazy if you used contraception? Yeah, it's interesting. What else is on your mind? Let's see, I think I see something in the chat box. Okay, IUDs. Yeah, IUDs actually got a negative rep, and rightfully so. But that was back in the 70s, and that particular IUD is not in use anymore. The new IUDs do not have the same issues that the Lippes loop had. So sometimes you'll still feel people or grandparents talk about them and automatically go, oof, no way.
I think there was another question in the chat, and it says, does an oral contraceptive lose effectiveness over time?
Absolutely not. And think about it, you're taking a pill every day that stops ovulation, thins the endometrial lining and thickens cervical mucus. And you're taking this medication that's absorbing every day within the system. And so, no, it does not lose effectiveness over time. The medication has, as long as your medication, is not out of date and is effective, it should be. And it is a myth as well as like, oh, should I take a break from my oral contraceptive or any kind of contraceptive to get my body back in, having regular cycles on its own. And there really is no research that supports that either, that, oh, I won't ruin my fertility over a period of time if I give myself a break. It doesn't hold true at all. Sounds interesting, and sounds like maybe, but really research doesn't support it. That all of the methods work consistently if used the way that they're intended.
Someone else put something in the chat. Do you
Okay.
think that there is a reason that there are many more options for contraceptions in women and not for men?
Well, I mean, research really, I do think that they're coming out with more options in men, but they're not there yet. I agree that research really does support why there's more in women. I guess you're stopping ovulation versus working with sperm. But if you think about the amount that are out there, the spermicides, the spermicide gels, all of those do work against it. But in the hormonal sense, you're right. Those are all just very women focused. Why? Since I'm not a researcher, I really can't answer that. But I agree, it does make you stop and go, wow, it's a little skewed. But yeah. And so hence, trying to give some of the control back to men, condoms do work if you use them.
I also had a question about,
Sure.
I feel like I've heard for a lot of time that antibiotics like clash with birth control and like make them not effective. Is that true?
There's only a few, very few, that affect oral contraceptives. Not now, it does not affect the vaginal rings. It doesn't affect the patches. It doesn't affect the injections or the IUDs. It only affects oral contraceptives, and there's only a few antibiotics that it is, very few. And if you think about it, if antibiotics can cause diarrhea or a stomach upset. If you are vomiting or have diarrhea, and then what makes you think your oral contraceptive is being absorbed? So in that manner, if you're sick, think about that. So it's not just it's just not antibiotics. If your GI system is upset, then this thing's traveling through too, and could affect absorption.
I think those are all the questions we have today. So thank you, Dr. Ketchy, for speaking and presenting for us. And thank you everyone who came to our event. I hope you all have a great afternoon.